Lassen, pediatric psychologist here at the University of Kansas Medical Center. I've been here about 12 years, and I'm also part of the workforce task force here through the health system on suicide prevention.
Great. We have a few others in the room today, so I'll let them jump in and introduce themselves as well.
Hi, my name is Alice Zhang. I'm a postdoc fellow on this project.
Hi, am I on? Okay. Hi, I'm Michelle Utt. I am a program manager for the TelehealthROCKS.
And I'm Robert Stiles. I'm another program manager and here to respond to your comments. And Michelle will be sharing those as we go through the presentation as well.
Absolutely. And Evelyn, are you on? Did you want to introduce yourself? Okay. She might not be in yet, but Emily, do you want to just go ahead and say hi? You have to unmute yourself, I think, or maybe we have to unmute her.
You're unmuted.
There we go.
Okay. Hi, I'm Emily Demo. I'm a school psychologist in the Blue Valley School District, and I'm excited to share with you all today what we're doing here in Overland Park and Leawood and Stillwell.
Great. Thank you. We're so glad to have you all. Have we had some people chat in, maybe some of the things they're already doing and some challenges they face?
So one comment was today is National Coming Out Day, so please be mindful of our LGBTQ folks as their attempt rate is much higher than straight folks. So when the youth complete an IA, they are complete. Sorry. Oh, Heidi Boehm from Kansas. One challenge we have is developing the appropriate interventions for patients that screen moderate risk for suicide in the inpatient and ambulatory setting.
I see some challenges coming through.
Mm-hmm. As an elementary school, our screener is the questions about intent and availability. We have a district protocol to follow when a student says or demonstrates a possible concern. That was from Donna Glover. Okay. You want more challenges?
Yeah, a few more challenges.
Okay.
It sounds like there's some good things already happening, so that's great.
Challenges from Michaela Dreyer, collaboration between home and school for students with mental health concerns and suicidal ideation. Libby from Tonganoxie is we have a district
a little loud. Sorry.
Screener that we use. We have several resources we recommend to parents and will follow up with the student when they return. We struggle with knowing how to help students reintegrate back after an evaluation or short/long-term stay.
Great. And that's definitely a topic we're going to talk about. I think on the 25th is hospitalization and follow-up. So those are really good comments that I think that many people would also agree with. So hopefully we'll get to that as well. And hopefully we'll really get to address some of some new tools or maybe some old tools for suicide screening and risk assessment today to really keep kids safe and give you guys some ideas of things that you might be able to do where you're at. So I think without further ado, I'll turn it over to Dr. Lassen.
Okay, well, it's very good to be with you. I appreciate everyone participating. Lots of challenges. We're not going to be able to address all of those. Obviously, the challenges far outweigh the answers that we have to those challenges, but hopefully in the few minutes we have to discuss risk assessment, safety planning, and screening, you'll have a few more ideas to add to what you're already doing. So let's get through. Can I?
You can just tell me.
Okay. So nothing to disclose. And we'll keep going, advance. Advance. Okay. So let's get right into just a couple of different screening measures that you can think about using. Very important that you have a validated measure to use. And I know that might sound intuitive and not worth mentioning, but there are a lot of folks who are using measures that others have used and not really aware of the validity and psychometrics of the tool. Advance.
It's hard to look at the noise.
Okay, so a couple of questions for everyone to respond to. First question, do you have experience conducting suicide screening? And if yes, how confident are you in conducting suicide screening? So,
And while you're doing the poll, make sure your computer is muted so we can hear somebody.
all right, looks like we're holding steady. Looks like we got most response. So 63% of you have experience conducting suicide screening. And it's pretty evenly split, you know, in terms of the confidence that you have. Not too many of you are willing to say you're highly confident in conducting screening, but a fair amount of you really don't feel very confident. So hopefully this will change some of those responses by the end. Thank you for sharing that. Okay, next slide. Minimize the polling screen.
Okay.
Okay, so just a couple of screening options I wanted to highlight. There are some others, but these two have the best evidence to date in pediatric populations, and they're both free and they're both very easy to use. So those are kind of the criteria I used. The first is the Ask Suicide Screening Questions questionnaire. There's actually a whole toolkit that NIMH has developed around this particular screening device. It's got a lot of great content on it. It's got some scripts that you can use to be talking with kids about suicide. It's got a lot of background information and about the screener and about suicide and youth overall. So I'd encourage you to take a look at that toolkit and see if there are any of those particular strategies you could adopt. Let me see. So I have a screenshot of the ask that will show. Actually, I'll go to that now so you can see what it looks like.
Keep talking.
Okay, we'll just keep talking. So the Ask Suicide Screening Questions is the first screener. And then the Columbia Suicide Severity Rating Scale is the second. So there's the ask. It's very straightforward, very simple. Anyone can really be trained how to ask those in a reliable way. So as you can see here, just asking initially if there's any suicidal ideation over the past few weeks in a couple of different ways, and then thoughts about killing yourself in the past week, and if there's ever been any previous attempt. So any yes to those questions would trigger a positive screen, which would then lead to a secondary screen, which we'll talk about here in just a few minutes. So the second is the Columbia. I'll go back a couple, back. There we go. Columbia Suicide Severity Rating Scale, which is actually the scale that we've adopted as a health system to screen all University of Kansas health system patients who come through the doors. It's a little bit more involved, but let me show that too, at least the content. So again, it's fairly straightforward to use. These are the different content areas. Yeah, can everyone still see that? Mm-hmm. Okay. Different content areas. First area is just assessing for wish to be dead, and then we have non-specific active suicidal thoughts that are queried, and then 3 more questions about different variations of active suicidal ideation with methods, with intent to act, and then with a specific plan. So again, an answer of yes to either of those first 2 questions would then trigger a secondary screen in more depth by a mental health professional. So those are really the two I wanted to highlight. Again, there are some others. Let me also say that the PHQ, I don't know if anyone is using the PHQ, but we have specific evidence suggesting that that is not valid as a suicide screener. And I know that that's a common screening measure for mental health issues in primary care and in different settings. And used in that way, it does provide meaningful information, but it's just not a valid suicide screener. The same would be true of the pediatric symptom questionnaire, if anyone's using that. They've added one question onto the end of it that asks about suicide, but it's not a valid screener. So those are the two that would recommend most highly. Okay. So this is a tool that SAMHSA and NIMH have developed. It's called the SAFE-T, and I think it provides a really nice assessment process to try and put into place in your individual settings. The first step in that evaluation process is to identify risk factors. I think you talked some about those last week with Dr. Kane, but we certainly want to know how much at risk a youth is. And then the second part of that would be identifying protective factors.
Just follow along with your slides.
Okay.
Really.
I'll look at my good old papers as we're doing this. So the second part of that is to identify protective factors. We know that that's a very important part of suicide assessment. Oftentimes overlooked or not focused on enough, but those are factors that are going to decrease risk. The third is then the suicide inquiry or the suicide assessment, using one of those validated measures where you're really assessing suicidal thoughts, intents, acts, and behavior. And then the fourth step in that process is to determine risk level, and along with that, an associated set of interventions. And we'll talk about that as well a little bit later. And then to document, really important that we're documenting very well, very thoroughly all parts of the assessment, and making sure that we've got a good paper trail to limit our own liability. Okay. Let's see where we're at here. I don't know if anyone's discovered this app, the Suicide Safe app through SAMHSA. I think it's a fairly new app that's available, but it's a very good app for providers. A lot of the apps that you'll see that are focused on suicide prevention are for individuals that can be assessing their own level of risk. So this one's a little different, and I think it adds a lot of value to what's out there. It includes that SAFE-T process that we just went through. It includes some case studies. Really importantly, I think it includes conversation starters. One of the things that we know from training all of our staff here at the medical center is that there's a lot of discomfort using the language that we need to use with suicide screening. And so this provides some conversation starters, gives you some language for how to do that. Also has a nice treatment locator function, so you can look in your own area to see what mental health treatment resources are available. Has some training and resources, content, and then all of the crisis lines, the text, phone, and online information. So look at that. It's a free app, and I would really recommend it to everyone who's working in this area. Okay, so when we talk about screening for suicidality, we're really recommending universal screening. I think that that's really where the field is going. And it sounds like a lot of you are doing that already. But we want to be screening everyone who walks through our doors. Now, the frequency of that screening is going to vary depending on your own location and some of the other constraints with your own settings. But we really want to have that as our ultimate goal, is to screen everybody who walks through the door. When possible, it's good to be able to interview kids alone, not just adolescents, but even younger youth down to age 10 or so. Obviously, we're going to get some different information if we're able to interview kids alone. We don't want to push that, and there are a lot of parents who are uncomfortable with that. We've run into that, especially here in the hospital setting, inpatient setting, but we ideally want to be talking with them alone. Using open-ended, relatively non-threatening questions, such as, how have you been doing? What kinds of things have been on your mind or stressing you lately? And it may seem like a heavy question to ask, but asking them specifically if they've had thoughts of hurting or killing themselves is really important. And our experience has been that kids really appreciate that open dialogue, and it allows them to feel okay starting to talk about some of those things. And we know that suicidal ideation, suicidal thoughts at any rate, are very common in youth. Most kids will have at least one episode of having thoughts of killing themselves, if only in a passive way, wondering what the world would be like without them in it. So we want you to feel really comfortable using the specific language of suicide, killing yourself, and understanding that that's going to open up the dialogue and reduce suicide attempts and completions. Okay, so the secondary screening will happen whenever there's a positive screen to the universal screen. So the tools that we talked about before, those would be a primary screening tool, and then any yes questions to those would trigger a secondary screen to get additional information. So if there's suicidal ideation reported, we want to calmly acknowledge that we've heard what the youth has said, and that reassure them that we're going to get further help and assistance for them. Really, in that secondary screen, what you're wanting to assess for is severity, intent, and access to means. So frequency, duration, intensity of the suicidal thoughts, if there's any plan or timeline, and then how accessible any means are that they report to you. And then, one particular feature of doing this with children is making sure that we're working closely with their parents and making sure that they're aware of the outcome of the screenings and what our plans are, what our recommendations are for following up. Okay. So in determining suicidal risk, it's helpful to think about risk in different categories. And one of the things I really wanted to emphasize to you is that suicidal risk is not eliminated, but we really talk about it in terms of managing the risk. And so for those who we would call high risk, those would be individuals who express having a plan to kill themselves and with some intent. And certainly a past suicidal attempt would put someone into a high risk category. Recent suicidal ideation or behavior, where there's current agitation, whenever there's an intent. Oh boy. Okay. We're gonna have to speed things up here because I've just been told we have 2 minutes. So a few minutes.
A few minutes.
Okay. So let's, and I apologize if we go kind of quickly through some of the rest of this, but I do want to get to some other things here. We
can skip that.
We're going to skip the question just for now. So the safety plan. The safety plan is really one of the foundational interventions that we have for helping individuals with moderate to high risk. So as components of that safety plan, we're going to want to help the individual understand what their warning signs are and really focus on identifying current coping strategies. This really isn't the time to learn new coping strategies, although that is an important part of ongoing intervention, but you really want to focus on what works for the child. Apps that they use, forms of distraction, other activities that help them calm down. Identifying responsible social supports, that really needs to include at least one parent. I know a lot of kids are hesitant to talk to their parent about this, but that can be an opportunity to really change the dynamic and improve interactions between parent and child. Certainly want contact information for professionals and emergency services, as well as crisis lines. And then making sure that we're talking with the parent about how to make the environment as safe as it can be by limiting any obvious ways for the child to harm him or herself. Okay, so the safety plan needs to be written. I would suggest that you use a template. There are several good templates available online, but it needs to be written. It needs to be given to the child. It needs to be in the child's chart and documented there. Really want to make sure that this is a family kind of intervention, and they need to be very involved. Focus again is really on positive coping, ways to boost mood, and identifying those triggers. And then we want to update the safety plan at every subsequent interaction and make sure that it's still meaningful, it's still working, it's still relevant for the child. And then make sure to document all of this. Okay, there's just a safety plan template. Again, there are others available online for you to look at, but this is a nice one that we've used a lot. Okay, so for lower risk, what are you going to do? You've identified risk. For those at low risk, what are you going to do? You want to at least arrange for some mental health evaluation. Again, these are potentially children who have had some passive suicidal ideation in the past. So we want some evaluation to be planned for, to collaborate with that individual, and to continue to screen for suicidality at subsequent clinic visits or at the school. Providing anticipatory guidance for effective coping. We're going to talk a lot more about building resilience and enhancing protective factors next week, but it's really important that we're not just trying to reduce risk through reducing risk factors, but really enhancing those protective factors that we know will also reduce risk. And then always reviewing the plan with parents. So those who fall into the more moderate risk category, who are experiencing active suicidal ideation or who have had a past attempt, you want to arrange for more immediate mental health evaluation. And I know that this is a big issue for those of you throughout the state who just don't have the resources that you need. I know it's very difficult to find that. We've had a lot of success using telehealth applications for connecting mental health providers with individuals. And so that may be something that we can talk more about. But whatever the evaluation and the plan is for that, making sure that you're following up and that you're ensuring that the child and family are okay with that and they're going to follow through with it. Answering questions, educating about what the evaluation will entail. There's a lot of times a lot of distress around these evaluations, especially for kids who have never seen a therapist or counselor in the past. And then reviewing the safety plan document with the child and family. Okay, so for those at high risk, this is perhaps the easiest group to manage because it's so straightforward what needs to happen. I know in practicality it can be difficult, but for those at high risk, we really need to arrange for an immediate evaluation through the nearest emergency department. Again, need to really educate the child and family about what to expect. We'll address more of that content in a future session. and gain commitment from the family for the evaluation, and making sure that the child's not left alone until that evaluation is complete. And there's a lot of clinical judgment that you're going to have to make here around if the family is safe to transport the child to the emergency department, or if we need to arrange for an ambulance or something formal with the police department, for example. Okay, so I think we're just about through this. Just a couple of things to keep in mind. Really making sure that we're always emphasizing to kids and family that help is available. We know a lot about suicide. We know a lot about what tends to help with it, what tends to make it worse, and some good interventions. And so make sure that we're emphasizing that. And make sure that you're talking with others around you, other professionals. This can be very uncomfortable, very difficult content to manage. And so make sure that you're consulting with others if you're unsure, and making sure that you're always erring on the side of caution, I think is just another helpful hint. So with that, I think we'll
so
wrap it up.
we are going to move right over to Emily, and we'll leave the questions for the end. I know that I'm happy to stay a few minutes after to talk about some of the questions. Hopefully Dr. Lassen can stick around a little bit for a few minutes afterwards. We also will be looking at all those questions and try to respond to those over the next week, or at least in some form or another. So we really appreciate all your comments, and we love that you're I can see that people are answering each other's questions and giving ideas. So I really love that. So just keep that up. And we're listening, we're reading those comments and questions, and we're planning to address them, and we really appreciate them. So without further ado, let's switch over to Emily Demo. And she needs to unmute herself, and then we're giving her control of the slides. Right? Okay.
Okay. So as noted earlier, I am a school psychologist within the Blue Valley School District, and you can hit advance, please. So those of you who currently work in a school district will be familiar with this, but just a little bit of information in regards to what we do for all staff within the school district in response to suicide prevention. The Jason Flat Act necessitates that we give training to all school employees. That includes bus drivers, people who work in the lunchroom, everyone who has any interaction with students, that they are mandated to have a minimum of 60 minutes per year in relation to suicide prevention, suicide warning signs, and knowing the protocol, what we would do within our school district. Advance. So the roles of schools in prevention, obviously students spend a majority of their day within the school setting 9 to 10 months out of the school year. And so we have a significant role in preventing suicide. And so we're protecting and educating, we're providing education for families, for the community, for our staff within the building. We're providing support for the students and their families and guardians. We can initiate that help and provide some of the resources, and we'll get to that in a little bit in regards to our specific suicide prevention protocol and the resources that we provide in Blue Valley. We're partnering with our community. So with us, we partner with KU Med Marillac and many other community health, mental health agencies in providing support for our students. We're helping students learn coping skills. We're doing lots of universal screening, universal lessons in regards to protective factors and resiliency, starting at preschool and up, to hope to get some of those protective factors in place for our students. You'll see the last thing that's noted there is called Securely. So our district has recently gone one-to-learner or a one-to-one device in middle school and high school for our students. And so Securely is something that is on every single student's computer. And so anytime that they search something that would be classified as alarming on their school device, administrator and counselors get a notification of that. So if a student were to say, fastest way to kill myself, for example, that was one that we've seen multiple times, we would get an immediate email, and then we could pull that student for further intervention. Advance. Here's just a tiered system of what we're looking at. Again, tier 1, we're providing support and education for all students, for all staff. For more of the at-risk students, we are providing some individual small group counseling. That might look like working with a counselor, school social worker, school psychologist. We're helping students get some services if needed, helping them to connect to community agencies, community resources, providing clubs. We have a Rebel Club. There's multiple other clubs within the school district that provide some of those supportive places for students to go. And then that, of course, tier 3 is when we're doing a specific suicide risk assessment with a student and moving forward with a plan of action for them. Advance. So our specific Blue Valley protocol, so anytime a student concern is reported to us in regards to a student, that can come from a parent, that could come from a teacher, any other staff member, a friend, however that concern is given to us. We being a member of the mental health team within the school, so school counselor, school psychologist, school social worker, would pull that student from class and begin a discussion with them. The Columbia Suicide Severity Rating Scale is the scale that we use within our school district. So thank you, Dr. Lassen, for going through what that is and familiarizing everyone with that to some extent. We train all of our mental health staff and administrators every year on this protocol, so they're familiar with doing it. And we provide support and training if they feel that they need some more information about it throughout the school year. If they need, they're not comfortable with it, they need more information, because that is the only protocol that we're using. Next. So here's a screenshot of what our suicide risk assessment looks like. It's based on the safety protocol with the Columbia Suicide Severity Rating Scale. And so in 2017, there was a group of individuals within the school district that got together. We looked at best practices, current data, and wanted to see how can we assess our students more effectively for suicide risk. And so this is what we came up with. We do have a manual within our school district. This is a piece of the manual. Again, this is the assessment that we're using, but we have a manual that provides additional information for staff and has additional resources, including safety plan, reasons for living cards, and some other documents that I'll go through here in a couple minutes. So you can see, again, we're going through trying to determine risk level for students. For us, you can advance, please. And so again, this is just the second page of it. Internal, external, we're looking at some protective factors, and then we want to know specifically about frequency, duration, controllability, deterrence, and reasons for the ideation. You'll see at the bottom, we've added some additional follow-up questions just in regards to safety being within the school. If a student has anything on them or on their person that would cause concern. And the last piece would be, could an administrator check a bag or pockets of the student? That is something that we do if a student would explicitly tell us that they have something on their person. Of course, we're a school setting, so weapons, different things that would harm either themselves or others, we have to address that. So that's a piece that we got some feedback from our school resource officers and administrators that they wanted that to be a part of our protocol. Advance. And then this is the last page. And so you can see based on the students' responses to the risk assessment, we would either say low suicide risk. We say low, or we would say risk present is language that we use frequently within our school district. We tend to say if we're having the conversation with a student, there's risk present. They've said something or done something that has raised the level of concern to the point of doing a suicide risk assessment. So in terms of talking with parents and guardians about our conversation with the students, we would use words like risk present. Or high risk or moderate risk. Our response in the school district is the same for high or moderate risk. And you can see over on Blue Valley response what that is. So low risk, if we determine student to be low risk or risk present, we're contacting that student's parent or guardian immediately that school day and letting them know what their student has reported, what's occurred. We're providing them with some resources for additional follow-up. and we're maintaining that really close school-home communication, and we'll keep that up with that student because, again, we've notified and recognized that they're a student with a level of risk. If a student is in the moderate or high suicide risk level based on our screener, again, we're responding the same way to either of those categories. So we would be asking the parent or guardian to come in immediately as soon as they were able, and we're giving them community emergency response resources and asking them, typically we would ask them to go to KU Med Marillac for that additional secondary screener that Dr. Lassen had alluded to in his conversation. So we're saying that the student, we believe that they're at risk and that they would need to go in for that secondary assessment. And so in regards to parent or guardian picking them up, we hope that that would be the case. Sometimes that's certainly not the case. And if we need to get other agencies or support staff involved, school resource officers, DCF, we would do that at that point due to a safety concern for the student. So when we formulated our manual and these documents, we worked really closely with several community mental health agencies and Marillac. So our families typically will take this paperwork with them to the hospital for their assessment, and that just really helps with the communication, we believe, between the different agencies to help kind of show what was reported within the school setting, and then figuring out what's next, what's needed for that student. We also want to look at the very bottom. You can see a couple additional other pieces that we've added on that's not a part of the Columbia Suicide Severity Rating Scale would be school attendance and discipline or legal issues. So we're really interested in, has there been a change in attendance? When we pulled some data from suicides that had occurred within our school district in 2011, the only commonality between all of the students who died was that their school attendance had changed in the semester prior to their death. So that's something that we are very mindful of and are looking at frequently. And then discipline legal, we just want to know if there's something occurring in that realm that we can help address too. Advance. These are just our notes. This is just an additional piece of information that's our notes for writing some of those clinical notes, and then the communication with parents to address what the plan is moving forward. Advance. Sorry if I'm talking fast, I just want to make sure we have some time for questions. So this is just a summary of what I've essentially already talked about. So if you want to say next, please. So the parent guardian plan of action, this is a document that when the parents or guardians come to pick up their child, if they're at the moderate or high risk level, and we're asking them to go in for a secondary evaluation, we're asking parents to fill this out. So we're certainly going through their students' responses to our risk assessment with the families and guardians, and then we're filling this out. So we want to know, what are the parents planning to do? Hopefully they're saying, taking to Marillac, for example, in our community. We want to know if there's potentially an appointment with an outside therapist, counselor, psychologist. Student follow-up scheduled. We always follow up with a student upon their next day that they would return back at school. And so that would be a follow-up with one of the mental health staff members. And I'll talk about, if the student is hospitalized, we have a different protocol, but this would be if the student goes in for a risk assessment at, again, using KU Med Marillac as an example, and they're not admitted and they're back at school the next day, we would of course be doing a follow-up first thing that morning. And we're asking parents to sign and date that they understand what we're telling them and asking them to do, and that they're taking action now at this point for their child's safety. If it's the low risk or risk present level, and we're just contacting that individual parent or guardian via phone, so they're not actually coming in, within the building to have a conversation with us face to face, then the staff who contacts that parent or guardian would then sign and make a note, contacted parent via phone on, whatever date, had a conversation with them, and so kind of summarizing that conversation. Next. Okay, next. And I saw that somebody had asked about a reentry or kind of that follow-up meeting with families. And I think Dr. Lassen, you alluded to that as well. But we have a protocol if a student is hospitalized either acutely or more long-term through like a PRTF, we do a reentry follow-up meeting with every single student once they return to school. So you can see we, as a part of that, we want the student present, obviously parent or guardian, if appropriate for the situation, and then any other individuals, certainly a member of the mental health team, possibly an administrator, and then any other individuals within the school team that we would feel would be necessary for the specific student. So maybe if it's a student who receives special education services, potentially their case manager might be a person that would attend this reentry meeting. And so you can see we have some questions that we're wanting to talk through with the family. And then we have some questions that we're wanting to talk through with the student. So we have found this process to be extremely beneficial, and students have reported that as well. It helps them integrate back into school in a little bit more slowly of a way, but a more thoughtful way. If they haven't already talked with their therapist within the hospital setting about, you know, what are you going to say when people ask why you haven't been on Snapchat for the last 4 days, or where have you been, or, you know, questions, we can help them think through those things before they're thrown back into their math class and needing to work through some of those, you know, different questions that will come up from their peers. So we also, again, want to know about the safety plan. Was there a safety plan created with any of the outside resources? If so, we would really like a copy of that if appropriate. Typically families and students are willing to share that and talk through that. And then we can adjust and formulate a safety plan if appropriate for a school safety plan. Check-in dates. Our protocol within the school district is to check in with that student every single day for the first week upon their return to school, and then at a minimum once a week for the following 4 weeks. So within that first month of their return to school, we're frequently checking in on that student and reassessing the need, if we need to do another risk assessment, if we need to support something in a different way, just keeping that communication and connection open with students. So the reentry meeting, I think, is a critical part of helping students integrate back into school upon a hospitalization. So in a nutshell, that is Blue Valley's protocol. Happy to share, we can kind of work through that. Happy to share our resources with you all, a manual, if that would be helpful. We have found using this process to get great information, good supports for students. We've had good feedback from school staff and parents and guardians in regards to the effectiveness and helpfulness of the process. So happy to share information. Thank you. Hopefully there's some time for some questions.
Yeah. Thank you so much, Emily. I saw so much good feedback, and I think that from both of our presentations, you guys were just sharing such important information. Quickly, I just had a couple questions that were popping up that I was seeing that I had for Emily. You said you would share the resources. We could send that out if that would be okay with you guys, or is it also on like the Kansas, is it on the website? Is it on a website somewhere?
I'm unsure. I don't believe it's on our Blue Valley School District website. So Dr. Bellinger, I could just send those to our manual and we can get those out to whomever. Yeah, we're happy to share that. Absolutely.
And this is Robert. We'll be sending out a resource list after, along with the PowerPoint and video. So we'll include that in the email to all the participants.
Great. Wonderful. Well, thank you so much for sharing. I think that will be really helpful. I was also curious, I'd heard you talk before about next week we're going to talk about resiliency and some of those, but could you just touch on some of the kind of primary prevention things that you guys are doing, like from elementary all the way to?
So at our elementary schools, they use a program called Project Happiness. And so I believe they start that in 3rd grade. And it targets different resiliency skills, identifying emotions, talking with trusted adults, and many other components. I'm not at the elementary school level, so I don't want to talk too much about it and give you incorrect information, but it's called Project Happiness. And when we looked at many different programs for social emotional learning. That one just was a phenomenal one. And so again, I've heard really positive feedback in regards to that. At our secondary, so at our middle school and high schools, we use the Signs of Suicide program, and we use Lifelines at the high school as well. So those are our two more universal, all students. We do lessons, push into classrooms and do lessons on suicide risk and warning signs, starting at 6th grade all the way through 12th grade. And then we supplement with lessons and videos from Signs of Suicide and Lifelines, depending on the grade level. We've kind of broken it into, 9th grade gets this specific lesson, 10th grade gets a specific lesson, for example.
I love that. And I saw a question come through. Who does those lessons?
At the middle school level, it's typically the school counselors, and at the high school level, school counselors, school psychologist, and school social worker, we tag team those.
Great, thank you. We did get another comment that I guess, Emily, you guys are more famous than you thought. You're on the KSDE website.
Hey, well, good. I'm glad that's out there. Excellent.
So we'll send it out as well, just
Great.
for like easy accessibility, but it is on the KSDE website if anybody wants to search that. Lastly, a question I kept seeing come up, and we had this last week, was, and maybe I think Dr. Lassen and Emily could speak to it, but what if you have a parent that, you do all this this assessment and screening and safety planning, and the parent is not willing to take them somewhere, or how do you guys handle that from both ends of the spectrum, I guess?
Sure. At the school level, I can speak to the school level. It obviously, like many things, it depends on the situation. Our school resource officers could take the child into protective custody if necessary, if they deem them to be in an imminent danger, imminent risk. And they certainly have a protocol that they work through to make that determination. But they could take them into protective custody and get the student support. We would want to obviously try to do everything we could do to not have that happen. That's a lot for students. However, DCF, we would make a DCF report if we were concerned that the follow-up that we had recommended did not occur, child in need of care, safety concern. So we would make that DCF report, and then DCF would investigate and hopefully help provide some supports for that family. That's what our response is.
Okay, thank you.
Yeah, I'm not sure I have much to add. I agree with with what Emily's described. One of the things that we will often do is let either the emergency room or the facility know that the child is on their way, because what we've found a lot of times is that parents change their mind about midway in that car ride, right, as the child is refusing, promising to not do anything. And so sometimes they'll turn around. So it's really important that you notify the facility or the emergency department that the child's coming. So if they don't arrive, then law enforcement can go to the home and check. But you absolutely want to document this with DCF if they're not complying with recommendations based on child safety.
Yeah. And two, something that we've done, and I see that Michaela just noted this, if we're concerned, again, either that the child maybe isn't safe, like we've had some situations where the parent says, yes, I can transport the child in my car, I feel safe for that, but I'd like an escort. We can have our school resource officer escort them to emergency room or wherever they were sending them as well. That's something that we offer. Again, it's not something that occurs, I would say, very frequently, but in the event that it needs to happen, of course it does. And yes, following up, I completely agree with Dr. Lassen. We are always contacting where they're going, and I'm letting the family know when they take their child. Again, I'm using Marillac as an example, but I would say I'll contact Marillac and give them some information and let them know that they could expect you in about 20 minutes, because that's about how long it would take from our school to get there. So that's a piece of it too that's critical.
Let me just make one more note for those of you working in hospital settings, that if you've got a child in the hospital and the parent's really refusing to allow the child to be transferred to an inpatient psychiatric facility, if that's the recommendation, we do sometimes go to the court and request that the child be temporarily placed in state custody so that we can make that determination for them. It's a pretty severe step, but it can be done fairly quickly in most areas if there's an imminent danger to the child's safety. So essentially taking that decision making away from the parent. So when you've got some time, like for kids who are medically hospitalized, that can be another option.
I saw a comment from, we're going to wrap up pretty soon, but there's so many good comments. I saw a comment from Catherine from Lawrence, really just acknowledging that this can be so scary for parents. So I think sometimes as the educators and mental health providers, we get frustrated. We're like, why are they not responding to this? But it may be like really difficult for them to process themselves, and they may be really struggling with kind of their own mental health issues around this. And so figuring out, like, being empathetic to that and figuring out how to support them. And Dr. Lassen is a master at this, of supporting families, but really feel like meeting them where they're at and realizing, acknowledging this is really, really a challenging situation. And I think Catherine said from Lawrence that she even sometimes will go with the family to the ER or to offer that and say, I'll be there with you. I know this is hard. If you have that flexibility in your schedule, I think that would be a supportive way as well. So thank you for sharing that, Catherine. I'm going to say that we're going to stay a few minutes after for questions, but let's just wrap it up formally. So I want to thank you all for participating today. Please join us next week when we talk about protective factors and ways to build resilient communities. And Emily kind of shared some of those ways that they're already doing that in their district. And then in future sessions, we're going to discuss more details about hospitalization and follow-up, and then go into supporting survivors. So before you sign off, if you wouldn't mind, please sharing in the chat box one thing from today's session that you will take from this and that you will try to use in the future. Each week we'll share these comments with the group, just so that we can all learn from each other. So yeah, please, if you can, just share one little thing that you would like to take with you, or thing that you learned this week. And just thanks again for participating. We're so glad that you are here and sharing your comments and resources and questions. This is a really neat community, so we're really grateful that everyone could be here today with us to talk about this important issue. I'm seeing some things come through, so that's great. We'll definitely share that. So we had some great questions. We'll take a few minutes. Did you guys, are there some that we want to?
Sure, yes, I do have some.
Loud.
So, okay. So Amanda from Salina, she said she has a client who claims to not have thoughts of suicide, but says, I just feel myself going into a dark place sooner. I feel like, what's the point, ? And that was a quote. Would that be considered suicidal thoughts? What would protocol be?
Yeah, that really would fall under this category we talk about in terms of like a passive death wish, where there's talk about not living anymore, but in kind of these vague terms. Traditionally we see those as conveying less risk for some self-harm, but sometimes it's the initial kind of language that kids will use when they're trying to share something that's really hard, but they're not sure how it's going to be received, if that makes sense. So it can be kind of the start of a really important dialogue, and one that we can't minimize just because there isn't specificity to it. And so there would really need to be some additional evaluation, screening done there. Talking about this dark place, and there's several words in there that the individual is using that would cause us to be concerned. And again, what we see a lot are kids who are kind of tiptoeing around talking about this because they're just not sure how we're going to manage that information. And so they talk about it in vague, nuanced ways. And it's important that we see that for what it is and really reassure them that, that we can have the conversation and that we can work towards a solution for them. So I would say that even though the word suicide or killing oneself isn't used, it still represents a pretty significant risk.
Any other questions?
Another one was how public service can help/guide youth when they do not have assistance at home or in the schools. So this is from Charlene Mitchell at the Independence Public Library. So if she comes across someone, how does she assist?
So how does she assist if she comes across someone, or?
Right, she works at the
At the library.
library, so to guide youth that do not have assistance at home or in the schools.
Well, I think, Charlene, you're one of those kind of gatekeepers that we talk about, like emergency responders and school teachers and just all of these individuals who come into contact with kids at various points in their lives. And it's important that you have some resources available to you that you can pass on to kids and families as you have those experiences with them. But I think one of the things we don't want you to be concerned or shy about is talking directly with kids about what might be going on for them. Kids really want to know that there are those caring adults in their lives that they can talk to that are just going to listen. We don't all have to be mental health professionals to help kids through some of these times. And again, that's one of the hopes here, is that we're building a larger cadre of individuals who are able to have these conversations. We're never going to meet the need if we just rely on those who are specifically trained in mental health professions. And so being able to listen in a caring way and provide resources and direction, I think would be very helpful. And if there's anything institutionally that the library can do to make those resources available to families, putting up some signage around the library to start to normalize and the discussions and identify resources.
And would you connect them with what if there was an immediate risk that they shared with you as a librarian, or what would you recommend doing?
We always say the emergency room is kind of the best option if there's a safety concern. We're mindful of filling up the emergency room, though, with a lot of things that may not be appropriate there too. I think now, Charlene, you said that this person was hesitant to talk with their family, right? So we don't have.
She didn't know. I don't know that she has. It just says that she needs assistance.
I want to also add a piece.
Sure.
I feel like another thing that we can do is really to give them the resource they can go to. For example, like the National Suicide Prevention Lifeline that we're going to actually talk about next week during next week's presentation. That would be a great resource for you to give it out to the youth that you are encountering.
So they have someone to call if
Yes.
there's an immediate concern.
Right, so that would be one of the great resources that could be used really anywhere, is to advertise and publicize those text lines and crisis lines that are available. And those may be the best ones to emphasize, instead of trying to figure out which mental health resources there are available. Although, again, that may not be a bad idea for the library generally, to just have some of those resources posted. Some of the major, like Johnson County Mental Health Center for that county, or other county mental health centers.
So, and I see we still have about 60 people on, so let's take a couple more questions before we wrap up.
Okay, another one came from Reva. In my work with hospice, the social worker usually discussed this with the patient. She would have them promise not to hurt themselves. Is that important with teens also?
Absolutely, and in fact, some of the language that you use there suggests that maybe you're talking about like a no suicide contract, promising not to kill oneself. We've really moved away from that. Those are not effective ways of managing suicidal risk in kids, or adults for that matter. So we'd really want to just, remove that kind of language and just use it more of a safety plan for the individual. But absolutely, it would do the same thing for youth in those situations.
Wanted to bring up a tip that is great. In Garden City, they put the local crisis number and the National Suicide Crisis Line on the student ID that kids have.
Oh,
We do that as well in Blue Valley on the back of their student ID.
That's excellent.
That's great.
Yeah.
Yeah.
they always have it with them.
Yeah.
Very good. Another
All
one?
right. Yeah, this is like the last one. If the student IDs one of the stressors as unstable home life, do we contact DCF also?
Good question.
Good question. I mean, that's really up to your own judgment. Obviously, if you have any suspicion that there's any sort of neglect or anything at home that may be contributing to feelings of being unsafe, then I think you do have a duty to report that to DCF. I think if there's any way to have a family meeting where you can bring them in and do some further evaluation and at least make some contact with that parent, that would be beneficial too. Sounds like, from Emily's presentation that there's a lot of that in the Blue Valley district. There's a lot of family coordination. And so I think that would be more of a proactive approach, that you would actually try to make some better connection with the family, and maybe that's ongoing. Maybe there's some ongoing support that you offer the family. But yeah, I think in terms of safety and liability and things like that, you probably have a case to be made to make a report. But again, longer term, you want to really try to do what you can to strengthen that family unit.
And Emily, did you have anything to add? If kids are coming in and saying that that's part of their stress is the things that are going on with parents or at home?
Yeah, I would say I would echo everything Dr. Lassen said.
Awesome. Okay. Well, I think we got to a lot of your questions, and if there's other ones, we'll be looking through those and be sending out everybody's comments and questions and hopefully addressing those, and then also the resources that were shared today, so you guys have access to those as well. So again, thank you for joining us today, and thanks for sticking around for a few extra minutes to talk about some of those important questions. And
Thank you, everybody.
we'll see you next week.